Today is Tuesday, November 14th, 2017. This is Hannah Crawford for the Global Polio Eradication History Project. I'm interviewing Dr. Stephen Cochi in Atlanta, Georgia, in the broadcast department at the Centers for Disease Control and Prevention in Atlanta, Georgia. Mr. Todd Jordan is our studio engineer and videographer. We have had one pre-interview session so far. Dr. Steve Cochi came to CDC in 1982 as an EIS officer after working as a pediatrician for the Public Health Service in New Mexico. And in 1987, he was at a PAHO meeting in Washington, D.C., which was his first contact with GPI. In 1993, Dr. Cochi became the first director of the newly created Polio Eradication activity, where he arrived with extensive experience in surveillance and immunization. He became the first Global Immunization Division Director in 1997. Today's interview will mainly focus on Dr. Cochi's direct experience working at the CDC and in polio eradication from his early career until 2001, at which time polio had been eliminated from all but 10 countries globally. This is the first of 2 or maybe 3 interviews. Thanks for being here today. It's exciting to have a chance to speak with you. And to begin, do we have your consent to conduct this interview and to record it?
Yes, we do, and thanks for inviting me, Hannah.
You're so welcome. Would you introduce yourself by name, say where and when you were born, and speak a little bit about your childhood, because we have some information on your early career from a previous oral history, but we don't have information about your childhood.
Okay, very well. I'll try not to bore the audience. My name is Steve Cochi. I was born August 19, 1951 in New York State, and grew up in Rochester, New York, in a family of 7. There were 5 children. I was the second oldest, and went off to college to MIT in the Boston area, and it was an eye-opener for me, because I spent my entire childhood without having left the state of New York. So I think that's it's very ironic that I am now involved and have been for decades in a public health adventure, if you will, that has taken me all over the world. I've traveled to 60 or 70 countries in the world, and I was really very provincial as a child, and had my first eye-opening experience when I went off to college.
But growing up, who were your influences? Who did you spend time with as a young child?
Well, interestingly enough, there were no physicians in my extended family, so I was the very first. But my role models really were people who I trusted, and mainly my teachers. My father, who became my high school principal, if you can imagine that. That was somewhat difficult, but I think it points out that I was very steeped in the value of education, and so my mentors as I was growing up were teachers, people in the education field who I admired greatly.
Could you speak about a few of them specifically?
Well, I was also an avid person involved in sports, and so I had a social studies teacher, Mr. Soper, who also was a football coach and a lacrosse coach, and I admired him greatly because he was a very bright, talented person, very engaging, had very good interpersonal skills, and he also really showed me the way in terms of how to respect people, how to interact people in a positive way, and how not to be selfish in the way you approached the world and life. So there were similar teachers and coaches, but I think he probably is the one that had the most influence on me at a very influential time of my life, of our lives when we're adolescents.
Do you remember any specific occasions when Mr. Soper modeled what it meant to be unselfish in the world, or to treat people with dignity, treat people well?
I think there were a number of occasions, like when we were playing a game of, and I think of a lacrosse game when we were pretty desperately behind. It was halftime, but he had the right approach. He had the right attitude. It was an attitude not to criticize and humiliate. An authoritarian attitude of that sort, but to try to look on the positive side. What were the good things that happened in the first half of the game, and what do we need to do a better job? I thought it was a very humanistic and proactive and positive approach to try to get the best out of people, and so I've tried to emulate that in my personal life and in my professional life at CDC.
Moving forward in time, so that would have been high school?
That was high school, and then I became a biology major at MIT, and I was beginning as a freshman. I was very interested in pursuing medical school and was fortunately successful and got admitted to Duke University and made quite a transition from the Northeast, from Boston to Durham, North Carolina, which at that time was a small, sleepy southern town in a state, North Carolina, that at that moment in time, most of the counties in North Carolina were dry counties. No liquor, no alcoholic beverages, and so and it was the Bible Belt. So I found myself in an interesting situation where, particularly when I went around on the wards at Duke Hospital, I didn't have a Southern accent. I was a Yankee, and even more, when I did some chit chat with the patients and their families, and they found out I was Catholic. I was a Catholic Yankee, so that was at that point in time in the mid 1970s. That was almost like being an alien. Times have changed dramatically since that point in time.
How would people respond to you?
Well, I think you have to recognize that a lot of these folks came into the tertiary care hospital in Durham, North Carolina, from rural parts of North Carolina, Southern Virginia, all over the place, and they probably never had seen or talked to or interacted with a person from up north, or maybe it was a rare event. So I think I was kind of a curiosity at that point in time for the folks from the rural South. Of course, things have changed dramatically in the decades since, and there's been a lot more mixing of the U.S. population. But it did teach me a lesson about how important it is to stop and understand diversity and value diversity, and not draw conclusions, based on first impressions or the appearance that this person is different than me, and therefore, I shouldn't trust them. I should be very wary of that person. And I've tried to implement that in in my life and in my work. And it's the diversity and what it brings in terms of different points of view, more collective knowledge is key to in the work I do. Global immunization is key to a successful outcome. You're more likely to have success if you have more people with diverse opinions, views, coming to the table to solve problems. And I think that's been one of the big successes of polio eradication.
When you enter into a room and a meeting, and you're encountering people who you haven't met before, how do you draw on that experience to implement some of those lessons that you learned when you were at Duke in not making assumptions quickly? How do you enter with openness?
Well, I do my best to try to engage people that I don't know and try to understand who they are, where they're coming from, what their experience is, and how that experience is being brought to the situation, the issues and the problems that we're collectively trying to solve together. And not preemptively prejudge or come to conclusions that may be totally inaccurate, totally false. So I think it's helped me.
I believe you returned to Massachusetts for residency after medical school. Is that correct?
That's right. And I returned to a pediatric residency at Massachusetts General Hospital in Boston. But before I say any more about that, one of the, I should say that probably the most important experience I had at Duke Medical School is the opportunity to get to know Dr. Sam Katz, who was one of the developers of the measles vaccine, and a pediatrician, head of the Department of Pediatrics at Duke at the time, and a staunch advocate of the value of vaccines in preventing serious vaccine-preventable disease, disability, death, and suffering. And he became one of my mentors to this day, really. And he just celebrated his 90th birthday. I was up at Duke University several months ago attending the celebration party for him, and he's still pretty sharp as a tack at 90 years old. I only wish that when I get, if I have the good fortune of reaching 90 years old, that I'll be even half as sharp as he is. But interestingly enough, not only did he help my career in terms because he had trained in the Harvard pediatric training programs, but he helped me to get this residency. And then after I finished my pediatric training and spent 2 years on the Navajo Reservation in the U.S. Public Health Service, serving as a pediatrician, and then came to CDC, lo and behold, there's Dr. Sam Katz as the chair of the U.S. Advisory Committee on Immunization Practices. We call it the ACIP. And this was in the 1980s. And he continued to serve both in the American Academy of Pediatrics and on the ACIP for the CDC, and was a chair twice for lengthy periods of time, and in between served as a member of the ACIP. And to this day, I've been able to enjoy both the personal friendship with him and the professional benefits and value that my relationship with him brought. He's definitely a giant in pediatrics, a giant in polio eradication and in measles eradication as well.
What is he like? What is his personality like?
He is amazingly, despite his many accomplishments, he is somebody who engages with everyone he comes into contact with. He has an amazing memory about who you are, your family, asking how things are going, and just getting on the right page virtually immediately. It's a skill that I wish I had, but he makes you feel valued. He makes you feel like he knows you and has a relationship with you from the get-go, and he does that to everybody. It's really amazing to watch, to observe.
Knowing him over time, has he given you advice? Would you say that he's influenced your leadership at all?
I think in very subtle ways he has. He's been a guide for me. He's been a compass. He is totally the opposite of judgmental. So he's very soft and not strongly directive in that way. But I think when you think of and I'll use this metaphor, it may not be quite so appropriate, but in the science of psychiatry is when you're trying to deal with a patient, you want to combine support and insight. And I think he had the perfect combination of supporting me and everyone else in his life, supporting our professional achievements, as well as giving some insight where needed about what our looking at our opinions or our strategies, our where we want to go, our decisions, and just giving some insight about the pros and cons of those decisions. So it's a wonderful combination. I was very fortunate to have mentors like him, but he really stands out because his mentorship cut across several decades.
Is there anything else you would like to include about Duke or your early training and education?
Well, I think the main thing is that getting into my career, I was searching. I was searching for what do I want to do when I grow up. What do I want to do with my life, and that brought me into the arena of pediatrics. I liked. It's always nice to be from my point of view as a pediatrician, to be able to take care of children and be an advocate for children. They're on the upslope of the curve, and they have so much promise. And I venture to say that sometimes as a treating physician, the children get better in spite of what you do. Whereas compared with being a physician who deals with adults that are on the downslope of the curve and trying to stave off serious illness and death. So it's I think it helped me. It's more my personality. It helped me to see the world optimistically, see the world as an idealist, because children have so much potential, and so the objective was to help them to realize their potential. So that was the first step that I took, and then I had to make a decision about whether I wanted to go into a subspecialty and be the best pediatric specialist with the knowledge of the right toe, or whether I wanted to do primary care pediatrics. And to help me get through medical school, I had signed up for a scholarship program at the U.S. Public Health Service that helped to pay for 2 years of my medical school education and provide a stipend, a living stipend, and in return I had to pay back 2 years. And this was something I was interested in doing anyway. So when the time came at the end of my residency, I decided to go to the southwestern United States and work as a pediatrician in the Indian Health Service of the U.S. Public Health Service, and was assigned to Gallup, New Mexico, which is right on the edge of the Navajo Reservation. The Navajo is the largest Native American tribe in the United States. They're about 250,000 in numbers now, and the Navajo Reservation spans the entire northern third of the state of Arizona, but it's in a very isolated, almost desolate part, high altitude desert. Of course, Indian treaties with the Indians being what they may, the U.S. government generally made a treaty that would confine the Native American population to the land that nobody else wanted, really. So anyway, with that in mind, it was a totally different experience from growing up in the eastern United States, living in a high-altitude desert in a very rural location. But it was, in many ways, it was fantastic because it taught me so many new things. It enabled me to really apply the skills that I had learned as a pediatrician in training, and also helped me to see the bigger world out there. I grew up and never left the state of New York as a child until I went off to college, and then ventured down to North Carolina to medical school. And that was a very different cultural and geographic environment, and this was different still. So I think these were like baby steps, which led to a career where I was flying all over the world and engaging with many different cultures in many different parts of the world. So, but the other thing about working in this environment is that we were responsible for taking care of the children on the Navajo Reservation. So it was very well defined. It was a defined population, and for better or for worse, we were it. We needed to tend to their curative care. We needed to tend to their preventive care, and including their vaccinations. And it helped me to start thinking in a public health framework, where in public health the patient is the community, and not the individual patient. And so when I decided, hey, I'm very interested in going to CDC to learn more about epidemiology and public health, it made that transition more obvious. It made that transition easier because I'd already started thinking in terms of a public health preventive medicine person.
Could you speak about a couple of specific times when you were working in the Navajo Nation where that interest in public health was kind of sparked? Like where you made the connection between the individual, the health of the individual being the health of the community?
Yeah. I think one example is that each one of the pediatricians, and we were 6 in numbers, and we had this big medical center, all of 150-bed hospital in Gallup. That so we were young and energetic and idealistic, but we each had responsibilities for a rural health clinic that we would go to one day a week. And mine was about 60, 80 miles north of Gallup. So in a very small town called Tohatchi, New Mexico. And I'll never forget going to Tohatchi and seeing 20, 30 patients in the course of a day, and in this very rural environment, and a third to 40% of Navajo of the Navajo in those days lived out on the reservation, where they had in these 6-sided hogans, houses with no electricity, with no running water. They had to carry their water in huge barrels from potable water sources, and so I felt a sense, such a responsibility to try to take care of the health needs of this very rural community, and I was it, So it really brought home to me the reach of public health, and also the potential fragility of public health if there weren't adequate resources available to meet the needs.
Did your mindset change a lot while you were in that position in the public health service? Like when you entered, what did you expect of the community, of your role there?
Yeah, it's a good question, Hannah. I coming from a large urban pediatric training hospital where one had exposure to the whole range of modern medicine. That was the mindset which I got on a plane and went to New Mexico. So, I began that 2-year experience, thinking like a pediatric clinician, and how can we apply, and this has included my other young colleagues who are mostly fresh out of training. How can we apply what we learned in these state-of-the-art tertiary hospitals and medical centers? And we did have to apply it because we had to take care of some very sick children. But I also had to confront that there was a lot more to health and medicine than taking care of children with life-threatening bacterial meningitis. That there were many primary healthcare needs that went way beyond those relatively unusual events. Adequate nutrition, vaccination, good, safe care of children by parents and extended family members. The sort of the basics of primary health care. And so, I was forced to confront that there was a lot more than intensive care units to delivering what to taking care of the health needs of children in the United States, including in this situation. And so, I was struggling by the end of that, and in the early days of my coming to CDC. What do I want to be when I grow up?
Could you talk us through the conversation that you had with yourself a little bit?
Well, to extend that a little bit, okay, do I want to be a pediatrician who takes care of individual children in the curative side, or do I see my future more in public health, where I have to let go of being a real doctor in terms of many people, the society in general, when they hear that you're a doctor, they ask, oh, well, where's your practice? What hospital do you admit to? So I had to make that transformation, just like everybody who ends up working in public health and has to, for the most part, give up seeing patients because preventive health care is what you're focusing on. So I had that struggle at CDC, and I wasn't sure, okay, is this for me, or do I want to go back and do a pediatric infectious disease fellowship at one of the, back up in Boston, and become a pediatric infectious disease specialist. But over time, the answer became clearer and clearer because I really grew to love the approach at CDC, and I'm one of the biggest fans of CDC. I think it's a fantastic institution, and it does so much for the American people and for the world. But it took me to the end of my 2-year EIS program to let go of being a real doctor.
Were you thinking about public health as systemic change? How did you conceptualize the role of CDC and what you would be doing and how it would, the scale on which it would operate at that point in time?
Yeah, that's a very good question, Hannah. I think the way I was looking at it was, you can do so much good for individual patients and see the results of your work within days. A child comes in very sick. Let's say the child has meningitis. You put the child on antibiotics, and they turn around within days, and you've saved them from serious complications like brain injury, like even death, and so you get the reward can come very quickly. Making the transformation to a public health point of view where it's a lot more intangible, but on the other hand, you have the potential to have so much more impact. It's not limited to the number of patients that you can see in a week or in a month or in a year. You can have an impact on an entire community, on an entire state, on the country, on the world, and that was ultimately the big attraction that drew me into the work that I do in polio eradication and in global immunization. Ultimately, it's amazing what impact those of us who work in prevention and in global immunization can have and have had. So I'm so grateful that I had the opportunity to go through these different stages and end up landing where I have landed, because I would have never predicted it at the start of this journey.
So you came to CDC in 1982 in EIS. You worked, would you talk about maybe we can skip EIS because I believe that's in Karen Torghaley's interview on Global Health Chronicles. Can we skip ahead to just before the polio eradication activity came into being, so maybe 1989 or so, or even before that? I want to go ahead and move into polio.
Yeah.
Could you find the beginning?
Sure. Well, I came to know many of the players during the 1980s in the evolving effort to move toward a global polio eradication initiative, which ultimately came into being in 1988 with the World Health Assembly resolution to eradicate polio from the world by the year 2000. But going back earlier, there were some CDC folks and some other folks that were instrumental in that coming into being, and they included D.A. Henderson, who was the head of the smallpox eradication initiative at WHO, who many people don't know was a CDC person going all the way back to 1955 when he came to CDC and was seconded in 1966 to WHO to lead the smallpox. I think it was 1967 actually, to lead the smallpox eradication effort from CDC. So he was a big player involved in the decision making about whether, following the eradication of smallpox, the declaration of this in 1980, whether or not polio or some other disease should be targeted for an eradication effort. Dr. Bill Foege, who was also a major figure in smallpox eradication from CDC, who became the CDC director in 1977 through 1983, and then went to Emory to found the Task Force for Child Survival, which created a multi-organization initiative, including WHO, UNICEF, the World Bank, the United Nations Development Program, and the Rockefeller Foundation, to dream big and to bring vaccines to the world's children, in the developing world's children, and achieve 80% coverage with all of the routine vaccines that children in industrialized countries had available to them, and to do this by 1990, and that target was reached by 1990. It was an enormous reach. It was an enormous example of thinking big, which is what polio eradication is all about. And Dr. Foege was a major figure behind the scenes, working with these same organizations and with the Director General of WHO at the time, Halfdan Mahler, who was a Danish, who was from Denmark, and was decidedly anti-eradication, decidedly anti-targeted disease. He was a proponent of health systems development, and he was almost dragged kicking and screaming into supporting polio eradication at the World Health Assembly in 1988. But his opinion was changed at a key advocacy meeting in the French city of Talloires, which is very close to Geneva, in March of 1988, just a few months before the World Health Assembly. And Dr. Foege and a few other notables, including Dr. Cyril de Quadros from the Pan American Health Organization, changed Dr. Mahler's mind. And lo and behold, polio eradication became an official target in 1988.
What did you hear about this meeting, and what did you hear about the resolution? Because you were at CDC at that time, correct?
Yes. I heard that it was had the promise to be an earth-shaking event, and there were some other big players in this, not the least of which was the leadership of Rotary International, which back in 1985 had signed on to the regional polio eradication effort in the Americas, led by Dr. Cyril de Quadros, who headed the immunization department at Pan American Health Organization, and Rotary got into this game in 1985 because it was looking for a global target, a global initiative that over the ensuing 20 years, a 20-year commitment through the year 2005, which would be the 100th anniversary of the creation of Rotary International. And so Rotary decided to jump in with both feet in 1985 and began a fundraising effort to raise $120 million. And over the next 2 years, they raised $247 million. But what's interesting about this from a personality standpoint is that the president of Rotary International in 1985, and they served for a 1-year period of time, was Dr. Carlos Canseco, who is a Mexican physician and who happened to be a good friend of Dr. Albert Sabin, who is the developer of the oral polio vaccine. And Dr. Sabin had worked very hard to convince Dr. Canseco, the head of Rotary International, about the how this would be a fantastic, this being polio eradication would be a fantastic initiative for Rotary to sign on to. So there was an apposition of different personalities and figures that kind of came together first in 1985 and then in 1988 that spawned or gave birth to polio eradication. But in the wake of that resolution in 1988, I think everybody realized, well, that's a very noble, idealistic initiative, but how are we going to achieve this? There were no resources. There was no fundraising beyond Rotary. There was no fundraising mechanism. There were no staff at WHO or at the country level that could be directly devoted to this. And so it took until the mid-1990s until most of the world and most of the countries in the world really got on board and started making any tangible efforts toward polio eradication. The only exception being that in the Americas, in the Western Hemisphere, there already was a polio eradication regional initiative that had begun in 1985 with a target for 1990, and that was ultimately successful in 1991 when the last case occurred in Peru. So that was some forward motion. And then in the Western Pacific region of WHO, which includes Southeast Asia, China, and the Pacific, the Western Pacific islands, they passed a resolution to eradicate polio by 1995. And aside from those two efforts, the rest of the world, Africa, the Middle East, South Asia was sort of waiting around for something to happen.
1985 to 1989, you were an epidemiologist, correct? Working in surveillance?
Yes, in the immunization program, and polio was one of several vaccine-preventable diseases that I worked on, but primarily on the domestic side. Until 1991, CDC did not have a line item budget from the U.S. Congress devoted to polio eradication, or for that matter, for any other global health activity.
How did that come about?
Well, I think that's a very complicated question, and the answer is not entirely clear, but multiple people, the leadership at CDC, particularly in the immunization program, and the leadership, past leadership from CDC, like Dr. Faggy, worked to build advocacy for a budget line item to be created, and it was put forward to the Health and Human Services Secretary, and then on to Congress for consideration, and it was ultimately successful in 1991, but only after a period of years of advocacy. I think it definitely was helped by the fact that the polio eradication effort in the Americas was proceeding very successfully, so that by 1990, 1991, there was virtually no polio in the entire Western Hemisphere. So I think, again, success breeds success. So I think that it enabled us to get, for the first time, earmarked resources to pursue polio eradication. And during the 1990s, as we had more and more success in the rest of the world, our polio budget grew from $3.1 million, which was the initial line item in 1991, to today, where we have a line item of $174 million and well over 200 staff that are working on polio and other global immunization activities at CDC and in the field.
In the late 80s, could you talk about the team of people, the group of people, yourself, Olin Q, Mark Palanch, Bob Keegan, and I think Walt Dowdle was around at that point, but in a role, he did not become part of the polio eradication activity. But could you talk about the group of people who would become the polio eradication activity in 1993?
Yes. You named most of the people who were involved. It was a very small group, a very small but dedicated and idealistic group. I keep using that word idealism because I think it's an essential element to be involved in an eradication effort. You have to have a positive attitude and an idealism, because it's such a big picture kind of thing. It's so far-reaching to try to eradicate a disease from the world, and there are going to be so many setbacks and so many problems and issues that you have to grapple with along the way, that in order to persevere, you have to have a positive attitude and an idealistic view, and that's the way the group was and is. We were very much helped along the way by Walt Dowdle, who was then the deputy director of CDC, and actually became the acting director for a year in the early 1990s, who provided some very senior mentorship and guidance and direction. And after retiring from CDC in the mid-90s, he went over to the Task Force for Child Survival, now called the Task Force for Global Health, and became a tireless advocate for polio eradication, and had many contributions from a scientific, technical, and advisory capacity, particularly in the realm of helping to build the global polio laboratory network that is the finest state-of-the-art network in the world for any infectious disease today. So in those early days, there was so much to do, and there were so few of us, so we had to provide moral support for each other. And when I first, just before I got into this game, or as I was beginning to get into this game, there were, I think mainly due to some personality issues, some tensions between the epidemiologists and the program people on the one hand, and the laboratory people, the virologists on the other hand. The latter group being on occasion or from time to time being taken for granted too much for the fantastic work that they were doing. And so just before I became the head of the what was then a brand new polio eradication activity at CDC, Bob Keegan, who became my deputy, started what he called beer diplomacy. So as a way to bring bring the group together. And this has been this is a tradition that has continued to the present day. Every Friday, going to Moe's Pizza, which is on the on the corner of Claremont and Briarcliff Road. Every Friday afternoon, at the end of the afternoon, we'd go and we'd enjoy each other's company, have a little beer and pizza, and talk through the issues of the week. And it broke any ice that there was, and we became deep friends as well as colleagues, and developed an enduring trust for what each other were doing that has continued to today. So I'm a big fan of beer diplomacy. It actually later on at CDC amazingly became. People would ask Bob Keegan, what's the secret? It became kind of a model of cooperation across different programs at CDC. People would come and ask us, how did we do it? Yeah. It's not rocket science, but it worked and still works.
What were some of the big issues that were discussed at Moe's?
Well, big issues. There were so many big issues. Well, first of all, I think we did our best to make sure that any tensions or resentments didn't build up. So we tried to clear if there was any need to clear the air that week, then we did so. But then moving beyond that, if at that time, we were dealing with 125 countries and on 5 continents at the start of this global initiative that were endemic for polio, and an estimated 350,000 polio cases in the world. That was a starting point, and we had a budget at CDC of $3 million and half a dozen people on the program side, and about the same, maybe a few more people on the lab side, and very few people at WHO or at other partners to deal with this. So it was daunting. So we would talk about, okay, what are the highest priorities? What do we do with the resources at our disposal, and how can we advocate to get more resources? And we started having success. First of all, we could build on the success in the Americas. We were pretty deeply involved in the Americas effort, especially on the lab side, since the CDC lab was the primary reference laboratory for the region of the Americas. But as a success occurred, we were successful in getting more and more resources, and the success builds on the success in terms of being able to deploy those resources, people and financial resources, both within CDC and assigning people to the field, primarily to WHO as on loan, on secondment, but also providing resources to WHO and UNICEF through cooperative agreements that we began in the early to mid-1990s, so that they could, since they have country offices in virtually every country, so they could expand their efforts and strengthen what they were doing. And so the partnership sort of began to grow and mature and become more stronger and able to do what seemed like an insurmountable task, but became less and less insurmountable over the course of the 1990s, as many of those 125 countries, which had polio, had endemic polio, but had, by and large, had fairly strong immunization programs, and with some additional effort, some selected polio mass campaigns could eliminate polio, interrupt polio transmission in those countries. And so we focused on those were the low-hanging fruit of the 125 countries, and so that and we were knocking them off one after another. So that amazingly, with relatively few resources, by the turn of the century, by 2001, we had gotten down to 10 endemic countries in the world from 125 countries, and we would sit back and say, "My God, that's amazing." Everybody was amazed, including ourselves.
It's amazing.
Yeah, and basically it convinced the world, or most of the world. There were still many critics out there, that yes, this could be done. One of the major drivers of this outside of the Americas was China. China had a huge polio outbreak in 1989, 1990, in spite of having pretty high routine coverage with polio vaccine, 10,000 cases. It was devastating to China, and it wasn't the kind of situation, a face to the world, that they wanted to portray. So the government got fully behind polio eradication after that experience, and began doing national immunization days, nationwide polio campaigns, beginning in 1993, with the president of China, chairman of the party, delivering the first doses. And I was in China. This was in December 1993, bitter cold in Beijing, but he was on television everywhere. And the similar ceremonies were being held in all of the provinces and prefectures of the country. And within 4 years, from 1990, well, this was actually 1993 when they went nationwide, but by the end of 1994, through multiple rounds of polio mass campaigns, China completely stopped polio virus transmission in the country. Another amazing feat. And it was one of the big drivers that convinced people, along with the decline in the number of polio endemic countries to only 10 countries by 2001, that gave people confidence that, yeah, this can be done.
To return to the beginning of the history of the program, so in 1993, Bill Clinton becomes president of the U.S., and he begins the National Immunization Program, which supports routine immunization in the United States, also supports a case for supporting polio immunization at CDC. Would you say that that's accurate?
Yes, and just to expand on that a little bit, one of the precursors to this happening was in 1990-91, the U.S. experienced, and this was when George Bush Sr. was the president of the United States, the U.S. experienced an awful, horrific resurgence of measles, with measles epidemic of 55,000 cases and more than 120 deaths due to measles. This is in the United States of America, 1990. It was a total embarrassment, and it uncovered weaknesses and shortcomings in the U.S. immunization program that ultimately led, after Bill Clinton took office, in the President's Childhood Immunization Initiative, a huge increase in the resources, priority, and attention given to the immunization program in the United States. And our polio eradication efforts benefited from this because we were the international arm, even though it was a tiny arm, of the new national immunization program, and we benefited by being able to take advantage of some of those resources. And I think our budget increased along with the U.S. immunization, the domestic immunization program budget increases. We were helped very much by Senator Bumpers, who was the chair of the appropriations subcommittee that oversaw CDC's appropriations, and he was a strong advocate for immunization. Going back to the time when he was governor of Arkansas and had to deal with a large measles outbreak back in the 1980s in the secondary schools in Little Rock and other parts of Arkansas. But the other interesting thing about this is that an even bigger advocate was his wife, Betty Bumpers. And she and Rosalind Carter ultimately formed an organization called Every Child by Two, which focused on getting immunizations to infants and young children on time so that they are fully protected with all of the needed vaccinations by the age of 2. So it was Every Child by Two, and this is an organization that survives to today and has been a great advocate for children and for vaccines.
So late 80s, early 90s.
On through the mid-90s. We were able to grow our budget and the number of people, both on the CDC side as well as support through our cooperative agreements to UNICEF and WHO at the regional and country level. And so it was an acceleration. It was an acceleration of effort, of energy, of resources, of optimism.
On the day-to-day, what was your role? What were you doing through this acceleration daily in your daily work? What did this look like?
I was running around crazy, trying to keep up with the acceleration, trying to manage it, and trying to lead it with the help of Bob Keegan. So, when you're leading and managing an organization that's growing so rapidly, there are so many things to attend to and falling through the cracks. And I was fortunate to have Bob Keegan as my deputy. He was a consummate manager. He was a public health advisor at CDC. That's a nomenclature that describes a person who has a combination of management training and real-world operational management experience working at the ground level, and working up the system at CDC, whether it's in the sexually transmitted diseases program, the tuberculosis program, or the immunization program at the local, county, and state levels. And so he had all of that training and then some. He'd spent some time in Bangkok with our international efforts to screen refugees, and had gotten 5 years of experience on the international front before coming back to become the deputy. And so, we were busy leading and managing this burgeoning effort, and I was on the road I was on the road all over the world, attending key regional and country WHO and other meetings, making sure that CDC had a presence, making sure that the face of CDC was there, making sure that the other partners and countries knew that we were totally committed to the eradication of polio. I wasn't the only one on the road, but I spent an enormous amount of my time, which is why I have more than 4 million Delta miles now.
That's incredible. It's a lot of traveling.
It's kind of tiring to even contemplate that.
What kinds of
Pretty much all of those since 1993. Yeah.
What kinds of conversations were you hearing in meetings?
In meetings, there was always this mixture of, did we really do that? Wow. Combined with, is this insurmountable? How are we going to solve this problem? How is it even possible that we can that we can eradicate polio from India or from Vietnam or from fill in the blank country. So there was a lot of problem solving that we had to face and address. Talking about it at the meetings, but then after the meeting, what's our implementation plan? Is it going to work? Are we monitoring the implementation adequately, and making adjustments henceforth?
Would you say that you were drawing on your background in surveillance?
Surveillance is the bread and butter of what CDC is all about. We are a scientific and technical agency, but also a program implementation agency. And one of our biggest strengths, and I think the biggest strength that we bring to global immunization and to the polio eradication, is our knowledge and capacity to do both the epidemiological surveillance, the case investigation, the investigation of cases, and the diagnosis of individual cases, and our laboratory capacity, our reference laboratory, our ability to develop new diagnostic tests that make it easier to diagnose polio or any other infectious disease, and to disseminate that technology and the diagnostic capability to many laboratories around the world, and to manage that laboratory network through an accreditation process that tests laboratories, at least on an annual basis. Are they capable of doing the appropriate testing to get the right answer? And supplying those laboratories with the equipment and supplies that they need. And so that's been the story of CDC's laboratory network, and of our on the program and epidemiological side of what we do, one of the biggest strengths that we bring to the table, to countries and to WHO as the lead organization, as the world's health department, if you will.
So as countries, and I'm assuming ministers of health, were in these meetings, and you're communicating to ministers of health and medical staff, attending physicians, who else were you speaking with, and how would you address their concerns?
Well, at the country level, it usually wasn't the ministers of health, because these were annual meetings that were a review of polio and the other immunization programs aspects that were attended by the directors of the immunization programs of these countries. So they were at a substantially lower level than the Minister of Health, but at the operational level, at the level where we can make change, if we can provide the knowledge and the resources and help, support to these country immunization program managers and their staff, then we can make a difference, and we did. So it became a very enormous capacity building activity in every country, not in the industrialized countries by and large, but each and every one of those 125 countries, and even some in addition to that who may not have had polio but were threatened by the prospect of polio being imported into their country because they were geographically adjacent to a polio endemic country.
And vaccination rates were likely to be low?
May or may not have been low. Needed attention to make sure that they had a high immunity against polio to protect them against an importation and spread within their countries. And this applied to quite a number of the European countries. In fact, the European region did not certify, and this included the former Soviet republics, did not certify itself as free of polio, and that's 51 countries, until the year 2002, because there still was endemic polio and the threat of polio, particularly in the Central Asian republics of the former Soviet Union.
Kurdistan?
Uzbekistan, Tajikistan, Kurdistan. Well, the Kurds in southeastern Turkey were the last group of people who had polio in Turkey.
Okay,
Yeah.
thank you.
1998, I think, were the last cases in Turkey, which is a fairly well-developed country. So the Caucasus countries and the Kurdistan, or the Kurdish people in southeastern Turkey, were right next to Iraq and other and central and the Caucasian countries that still had a small number of polio cases even until the late 1990s. So I'm trying to portray a massive effort that cut across every WHO region except the Americas, which had successfully stopped polio in 1991, but had to sustain that effort against the risk of importation of polio for many years afterwards, right up to the present day. There's still a risk of the polio virus getting on an airplane and going almost anywhere in the world undetected, because most of the polio infections are silent infections. Only a small percentage get paralysis.
Could you trace the history of the outbreaks through the 90s as the program is growing and accelerating? Where was your attention? Where was attention drawn globally?
Yes. Going back to what we were talking about a few minutes ago, since we had insufficient resources, we had to focus on, okay, where do we have the greatest likelihood of making the most progress as soon as possible? And so after the Americas, the next region of the world, WHO region of the world that had the most infrastructure and resources at its disposal was the Western Pacific region, and that was spurred on by China, which with very few external resources did the job it needed to do, because at every level of the Chinese government, it's being a hierarchical government and society, once the decision was made that this was a priority, boom, it happened. But the Western Pacific region was the next region that was prioritized, and they had their last polio case in the region in 1997, and it occurred in Cambodia. Interestingly, near the Cambodia-Vietnam border, in the Delta region of southern Vietnam and Cambodia, and there was the boat people. It was the boat people who were basically migrants that rarely touched land. All of their commerce happened on boats, and they were in a population that wasn't being adequately accessed by your standard immunization activities. Even the polio campaigns had to be redesigned to not go house to house, but to go boat to boat, to extinguish the last polio viruses. But the last case in 1997, and then there was a certification of eradication in the region in 2002, and in 2000 and from in the European region, there was regional certification. So those were the big. There was the European region and the Western Pacific region that where the most progress was made over the course of the 1990s, leading up to this all-time low of only 10 countries being endemic in 2001.
So when you get the news that polio has been eliminated from an entire WHO region, what happens to acknowledge that? How do you, this is a bigger question about how you maintain this optimism and the perseverance of GPI, of polio eradication, because this is a massive effort and it's taken a very long time to come so far.
Yeah. Well, we maintain it by publicizing the successes, by publicizing the progress, by making sure that that's publicized not only to the public but to the people working in the trenches in the countries that still are endemic for polio, to show them and to give them a sign that you can do it as well.
So what happened when polio ended in WPRO, the Western Pacific region?
Well, there was some trumpeting from the highest mountains about this, and then there was the dissemination of that information and the know-how and the operational how they did it, and to other regions of the world that still had polio, and here's how operationally it was done, and let's consider doing it in a similar way. It may need to be adjusted for the cultural context of your particular country, but it gave people an understanding that this can be done, and we're getting help to get this done, and we can do it too. So it snowballed, and that's the way I would characterize the 1990s right up to the year 2001. It was like it was a snowball effect, and people were really, who worked in the program, were really riding high because the slope of the curve was just going way down, and it was a very exciting time. Of course, we were although we were spending some time in the most difficult, challenging countries, they were not the countries that were stopping polio transmission. And in the first decade of the 21st century, we had to confront that, which we can talk about in the next session. So
Pakistan, Afghanistan, India, Nigeria. The acronym was PAIN. The PAIN countries.
The PAIN countries, yes. I think that's probably the most appropriate acronym that we can use for what we had to confront in the first decade of this century.
But leading up to 2001, what happened from 1995? Actually, let's go with 1997, because you changed positions in 1997, correct?
I actually didn't change positions. Going back to what I was saying before, we started as a polio eradication activity in 1993. We had a budget of $3 million. We had 6 people, and plus we had the lab folks, but they were a few in number. I described a few minutes ago how our budget increased dramatically over the course of the 1990s, and the number of staff that we had increased. So I had the same job, but many more people and a much larger budget, and so we officially became a division instead of a minuscule activity of half a dozen people with a tiny budget. By 1997, in 1997 we actually had our name changed to the Vaccine Preventable Disease Eradication Division, because Congress had begun to give us a second line item to address measles, to focus on measles elimination. So we were not only the polio eradication, but also beginning to dabble in measles eradication. And by the end of the decade, we actually since we were beginning to work in all different areas of global immunization, not just polio and measles, we changed our name to be more generic, as the Global Immunization Division. So we were involved not only in disease eradication, but also in other aspects of immunization, of vaccines and global immunization, although our number one priority was polio eradication.
Wanted to see if you would talk about countries in which there was less infrastructure than in other countries. I'm thinking of South Sudan and Somalia in particular. Because a few minutes ago you also mentioned that there were some countries have been more challenging than others. So I'm wondering, through the 90s leading up to 2001, where the number of endemic countries is markedly, incredibly reduced, where did you meet challenges along that way through the 90s?
Yeah, good question, Hannah. When we're looking at that, the downslope of that curve, as I said, most of the countries that where we were successful over the course of the 1990s, although they were low-income countries, lower middle-income countries, and didn't have the ideal amount of resources, they still had basically had reasonably well-functioning immunization programs and systems. They may not have had optimally high routine vaccination coverage, but they had the capacity to do what was needed to in localized areas where they were still experiencing some polio cases, to do some additional strengthen the surveillance and do some additional effort both through the routine program and through polio mass campaigns to get rid of the polio virus. So that was a fairly large group of countries that enabled that downslope of a decreasing number of polio endemic countries to occur. As time went on, there's another set of countries, and you mentioned South Sudan, which at the time was still united with Sudan. It only became a separate country a few years ago. But South Sudan, another example, Somalia, which since the early 1990s has had no federal, national government that really had a reach throughout the country. It was split up into warring factions, warlords, and different jurisdictions. Other countries in conflict, Democratic Republic of the Congo, Afghanistan, Pakistan, and so on. So as the number of the low-hanging fruit countries decreased through our successes in the 90s, we had this totally separate group of countries where war, civil unrest, breakdown of civilization, if you will, the breakdown of any functioning health system had to be addressed in a very different way. And so it's in those countries, and I think South Sudan, Somalia are excellent examples of this, there had to be a very big buildup of a replacement for a non-functioning domestic immunization system. So the resources, there had to be additional resources provided to WHO country office, UNICEF country office, non-government organizations that were actively working in that country to deliver health services, to build them up as a replacement for a non-functioning domestic immunization system until such time as that could be restored. And, that still hasn't been restored in many parts of Somalia. It existed in Iraq, but then got largely destroyed, with the war. Same thing with Syria, which was a very high-performing immunization program for many, many years. And it's sad to see how the destruction of war has lowered vaccination coverage to 50 to 70%, depending on the part of the country, and caused the reemergence of polio. So over time, the program had to deal with, in an unprecedented way, with how to address these challenges and find new ways of operating. Be very creative. Be innovative. Yeah, and I think that's been the story of this polio eradication odyssey. Facing challenges, finding new ways to creatively and innovatively operate to get results, to make it happen. I think it's provided lessons learned that I think are applicable to other global health programs on how to go about addressing these issues. Afghanistan is an example where making the program work required engaging the Taliban, including the local commanders, and giving them, making them see that good health is good politics for their local communities, and allowing them to be in charge of creating the vaccination teams in the communities that they controlled, and giving the vaccine, providing the vaccine to them so that they could implement the program and show the community that they're doing something useful for the community. So that's, I think, just one of the many examples of innovation that have had to take place.
Would you talk about some of the staff people, individuals who've worked in country and been innovators, who would come to mind immediately?
Oh. Okay, well, in the early days in the Western Pacific region, we had assignees to China, Mac Otten, who we assigned there back in 1992 before the first polio national immunization days in China, and he's an imposing figure at 6'7" inches, and a staunch advocate, proponent of disease surveillance, of polio surveillance, and of mapping polio cases, and he brought that both that energy and that knowledge to the program in China, to the point where they became sort of they became a model for the world, really, on how to do polio surveillance, only exceeded later on by India. But he was so interested and engaged in the surveillance system and in mapping that I used to call him Map Otten instead of Mac Otten. But so he was one of the driving forces in the early days. We also had a person assigned to Vietnam, another highly polio-endemic country at the time, Bernard Morinier, who was a CDC EIS officer who moved into the Global Immunization Division subsequently. And we had a person in the regional office, which was in Manila, the Philippines, Rudy Tungerman, who's a German national who had also completed EIS and then moved into polio eradication after a short interlude. In the Americas, we had Dr. John Andrus, who went on, who was sort of the deputy to Dr. Ciro de Quadros late in the polio eradication game in the Americas, and then moved to India, to Delhi, to lead the regional effort in the Southeast Asia region of WHO, and became a very important figure during the 1990s and the early 2000s in
reducing the polio burden in India. So those are a few of many people. Hamid Jaffrey, who we assigned to the regional office, the Eastern Mediterranean regional office, which at that time was in Alexandria, Egypt, later moved to Cairo, Egypt. And then his counterpart in the European regional office, Steve Wasilek. So those folks are still around and are still working on polio eradication aspects. So we had the good fortune of having an unending stream of talent flow into the program and really bolster what it was that we needed to do.
The GPI History Project archivist, Laura Frizzell, and I were in conversation about different periods of time in which there are tons and tons and tons of documents, and also with the staffing increase, there's this expansion for her and her role as well of items to collect. So my question is, how cohesive was the staff through the 90s, through this giant expansion at CDC and more broadly?
Well, one of the very fortunate things in which I think made it work, there was a chemistry, there was a cohesiveness, there was a camaraderie, and that still exists today, but it was really intense, very intense in the early days, because there were fewer people, and we were drawn together by adversity, if you will, by the monumental challenges that laid ahead. And so I would describe it as a highly cohesive, like a family, and we took care of each other and looked out for each other. And I think the Friday Mo's events, it wasn't just a symbol that was sort of narrowly defined or superficial. People really went there to unwind, to enjoy each other's company. I mean, it wasn't a requirement that people socialize, but that's just the way it evolved. We were a very close and tight-knit group, and I think that contributed greatly to the success we had, because the work required perseverance. The work required hanging in there despite adversity and despite setbacks, and so for whatever reason, it attracted people that were crazy enough to just hang in there and work very hard for a common goal.
Could you describe an occasion or two when you saw people really needing to go to Mo's?
Yeah. Well, yeah, I mean, when we would have a setback, and I think I think a setback that we had in the year 2000 in Hispaniola, the island that includes Dominican Republic and Haiti, where we had our first well-documented outbreak of vaccine-derived polioviruses, and we had to confront the fact that we were looking forward that there was a world where at least rarely the vaccine virus that in the oral polio vaccine, the Sabin vaccine, rarely and usually under conditions where there was low vaccination coverage, so a lot of susceptible children around in the communities. The vaccine virus could rarely mutate sufficiently to where it could take on the characteristics of the wild or naturally occurring poliovirus. So we had this outbreak happen. It was almost entirely in Haiti rather than Dominican Republic, of I think it was 21 cases ultimately, and the outbreak could be terminated in the same way as we approached the wild or naturally occurring polio viruses by doing multiple rounds of polio mass campaigns, and it was terminated. But we had to confront the fact that we're probably going to be seeing more of these, and the realization of that, I think, we had to share our disappointment over beer and pizza at Moe's, and try to make sense of what this had happened, what this means, how do we have to prepare for going forward for the future. So that was one prominent event, I think, that got played out in Moe's, not just 1 week, but on a regular basis.
I have some follow-up questions. I'm also noticing that we are at time. We're just a few minutes before time. So maybe, where do you think we should end for today from 1980? And I have follow-up questions. We'll do another interview, so I can address the follow-up questions I have in the beginning of the next session.
I think we should end by just stating the fact that entering the 21st century, there was a lot of optimism and well-deserved optimism that we had made so much progress, and it had really helped to support people and organizations who are very heavily involved in the program to move ahead in spite of the fact that we had not eradicated polio by the year 2000, which was the original goal from the World Health Assembly resolution. So, of course, when you're eradicating a disease, it's all about zero. Getting close is still a failure, but nobody would have imagined in 1988 or even in the early 1990s, when the program was moving along at a glacial pace, that we would have gotten as close as we had achieved by the year 2001. So in a way, that was a major milestone. That was a major victory that we were down to 10 countries, and re-energized everybody to be able to move forward.
Would you say a bit about that, where you were when you heard that you were down to 10 countries, that moment?
Well, it wasn't a single moment, to be honest with you. We were watching, we had to watch the weekly surveillance data and the statistics in every country, and even after the end of the calendar year, since there's some lag in reporting of cases and in the laboratory results, we didn't know with an absolute fact until a few months into 2002 that we could declare that there were only 10 polio endemic countries. But where was I? I think where we celebrated this the most was we were continuing to have annual global meetings, and beginning in 1996, these were hosted by WHO in Geneva, and I can remember very well in the 2001 meeting where we were anticipating that there were only now 10 remaining endemic countries, that was something that was made very clear in the presentations and in the summary of the annual meeting, and something that brought pride and optimism and sort of let's roll up our sleeves and get the last 10 kind of attitude, kind of behavior. So it was a great way to end in the annual meeting in 2001 to be able to realize that milestone.
Is there anything else you want to add for today?
I think I'm pretty talked out for today.
Thank you so much, and we'll schedule session 2.
Okay.
That's great. Thanks.
Yeah, thanks.